Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology, okay? Now, what's happening in this image? There looks like there's been some sort of vertical surgical incision in a very young child, baby perhaps. Could this be a surgery to take care of a potential issue known as pyloric stenosis? Yes, that makes sense. You remember that? Pyloric stenosis? Well, we're going to be discussing this and much more in this section on stomach pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Highly recommend so that you can do your best on Step 1. So, stomach pathology. High yield things here: gastroschisis, omphalocele, pyloric stenosis, acute gastritis, chronic gastritis, peptic ulcer disease, and gastric carcinoma. So my future gastroenterologists out there, future pediatricians, future surgeons, this one's for you. Let's start with gastroschisis, okay? This is a congenital malformation of the anterior abdominal wall, which results in the exposure of abdominal contents, okay? Like in this cartoon. You should be able to diagnose this on the gestalt level, okay? Highly likely that you will see it in real life as well. Now let's talk about an omphalocele. What is that? Well, an omphalocele is a persistent bowel herniation into the umbilical cord, okay? To the right, you can see how that happens. But this is what it looks like in real life. Omphaloceles are caused by the failure of herniated intestines to return to the body cavity during development. An omphalocele consists of a peritoneum and amnion of the umbilical cord covering the abdominal contents. Now here's something you're likely to see on examinations and in the real world when you do your pediatric rotations. A pyloric stenosis, okay? A pyloric stenosis is due to congenital hypertrophy of pyloric smooth muscle. As we can see here on the right, on ultrasound of a 6-week-old child, we can see that hypertrophied pyloric smooth muscle causing pyloric stenosis. Pyloric stenosis is more common in males, and it usually presents 2 weeks after birth. Symptoms of pyloric stenosis include projectile non-bilious vomiting. You must know that. You'll see it. Also, visible peristalsis and buzzword olive-like mass in the abdomen. Pyloric stenosis is treated by myotomy, as you can see here, right? Speaking of which, since a lot of you watching this are future surgeons, how was this closed? Was it closed with primary intent, or did it heal with secondary intent? And I kind of already gave it away. Primary intent, right? Because actually that's the only one that's closing is involved with, right? The surgeons will suture or staple the wound closed. That's primary intent. Whereas secondary intent, the wound is just left open and free for all. Heal for yourself, right? This is primary intent. In regards to pyloric stenosis management, which you'll need to know even at this level, electrolytes may be necessary, and that's to replace what was lost during the emesis or vomiting. Here we have a horizontal pylorotomy scar. And as you can see, these patients go on to live long, fruitful lives. In regards to pyloric stenosis, endoscopy can show us a few things. For example, they might see other lesions or can clue us in on how small the lumen is, right? But here in this image, we can see those very small lesions. Now let's move on to another commonly tested entity, acute gastritis, right? Acute gastritis is due to inflammation of the stomach mucosa. Acidic damage due to the stomach mucosa may predispose patients to acute gastritis due to an imbalance between mucosal defenses and the acidic environment. Regarding acute gastritis, the gastric mucosal defenses include that mucin layer created by the foveolar cells, bicarbonate secretion by the surface epithelium, and adequate blood supply, which gives the nutrients and picks up leaked acid. To the right in this image, we can see acute gastritis occurring in the setting of a H. pylori infection, right? Speaking of which, with prolonged Helicobacter pylori infections, what lymphoma would a patient be at risk of developing? Malt lymphoma, right? You remember that, which is a type of B-cell lymphoma, right? Low grade, right? We talked about that, and I know you remember it, right? We just like reiterating things, right? Keep it fresh. Risk factors for acute gastritis include curling ulcers from severe burns, hypovolemia, which results in reduced blood supply, NSAIDs, decreased prostaglandins, heavy alcohol consumption, and chemotherapy. And keep in mind that increased intracranial pressure, i.e. Cushing ulcer, causes increased stimulation of the vagus nerve, which results in increased acidic production. Multiple stress ulcers may be visible in the ICU in patients who have experienced shock. And acid injury causes an ulcer. These erosions or even the superficial inflammation may occur due to the loss of the mucosal layer. Here we can see acute gastritis endoscopically. And here we can see acute gastritis with pit abscess at the microscopic level. Now let's talk a little bit about chronic gastritis. Chronic gastritis is due to inflammation of stomach mucosa that's been prolonged. Chronic gastritis is classified into two types based on the underlying etiology: chronic autoimmune gastritis or chronic H. pylori gastritis, right? Those are the two that you need to know. Chronic autoimmune gastritis is the autoimmune destruction of gastric parietal cells, which are found in the stomach body and fundus. Chronic autoimmune gastritis is linked to parietal cell and/or intrinsic factor antibodies. Clinical features of chronic autoimmune gastritis include atrophy of mucosa with intestinal metaplasia, achlorhydria with antral G cell hyperplasia and elevated gastrin levels, and megaloblastic anemia due to the lack of intrinsic factor. Patients with chronic autoimmune gastritis have increased risk for gastric adenocarcinoma, intestinal type. Chronic H. pylori gastritis is due to H. pylori-induced acute and chronic inflammation. Chronic gastritis due to H. pylori is the most common type of gastritis, right? And you can see that even on this histological section. If you look in the middle here, you'll see all these very small, linear-shaped H. pylori, right? You see those? That's literally the H. pylori. Mucosal defenses are weakened by the H. pylori ureases and proteases, as well as inflammation. Regarding chronic H. pylori gastritis, the antrum, the antrum is the most common site of involvement. And symptoms of chronic H. pylori gastritis include vague abdominal pain and diarrhea. In chronic H. pylori gastritis, there is increased risk for ulceration, gastric adenocarcinoma, and malt lymphoma. Treatment of chronic H. pylori gastritis involves triple therapy, which I know you know, because you like making me proud, right? I know you know this. Proton pump inhibitor, clarithromycin, right? And an antibiotic, such as amoxicillin or metronidazole, right? I'm so proud of you. You're so smart. And keep in mind that treatment of chronic H. pylori gastritis usually resolves the gastritis and reverses the intestinal metaplasia, right? Because we remember that metaplasia is reversible, right? We remember that. The absence of stool antigen and a negative urea breath test both attest to the eradication of H. pylori. Here we can see a H&E stained representative micrograph from a patient with H. pylori gastritis. Now let's talk a bit about another important condition known as peptic ulcer disease. Now this is mucosal ulceration occurring in the gastrointestinal tract, specifically peptic ulcer disease. Right? You see that? This is a great cartoon. Now, peptic ulcer disease commonly involves the proximal duodenum. That's 90% of cases. Or the distal stomach. That's 10% of cases. And causes of peptic ulcer disease include H. pylori, right? This is nearly often the cause of duodenal ulcers, greater than 95% of them. Or Zollinger-Ellison disease, right? NSAIDs can do it, as well as bile reflux. Peptic ulcer disease presents with epigastric pain that gets better with food. Pass me the Doritos. Here we can see peptic ulcer disease from a specimen that was actually removed via gastrectomy, right? So this is what it looked like grossly wherever the pathologists were. Hopefully the stomach doesn't need to be removed, or partial portion of the stomach. Generally, this is seen on endoscopy, which will show Brenner gland hyperplasia and ulceration at the site, whether in the stomach or the duodenum. And in regards to peptic ulcer disease, keep in mind that they may rupture, resulting in acute pancreatitis or anterior ulcer bleeding from the gastroduodenal artery, right? And note, the smaller curvature of the antrum is where an ulcer is most frequently found when in the stomach. The left stomach artery may bleed during a rupture. And the majority of benign peptic ulcers are small. How small? Smaller than 3 centimeters. And they're usually well defined and encircled by radiating folds of mucosa. Isn't that nice? Wow. Nearly seldom are duodenal ulcers cancerous, right? However, if there is a suspicion for peptic ulcers, there should also be a suspicion for carcinoma, right? So have that on the differential. Because gastric cancer can result in stomach peptic ulcers. Malignant ulcers tend to be big, asymmetrical, have piled up margins. So we need a biopsy, right? We need pathology to weigh in on this for definitive diagnosis. Here we have a cartoon showcasing the peptic ulcer treatment, various pharmacology for various drugs that can be utilized. Keep in mind that protein pump inhibitors may be useful, antibiotics may be useful, especially in the setting of H. pylori, right? Now, what are we looking at here? Well, we're seeing a duodenal ulcer, right? This is an aspect of ulceration. And here we can see a micrograph showing erosive gastric ulcer, right? Now, it's always important to remember that medicine is a practice. So sometimes it's a bit difficult to say exactly what we're looking at, as these endoscopic images showcase. Now let's move on to gastric carcinoma. This is important because gastric carcinoma is the malignant proliferation of surface epithelial cells in the stomach, right? For example, take a look at this H&E section from an adenocarcinoma of the stomach, right? So regarding gastric carcinoma, there's two things that we need to know at your level. We need to know there's a diffuse form and an intestinal form. Okay? Gastric carcinoma is subclassified as diffuse or intestinal. Laparoscopy of gastric carcinomas typically show a big, uneven ulcer with heaped up edges, looking all gross, which characterizes the intestinal type, which is more prevalent. And keep in mind that gastric carcinoma typically affects the smaller curvature of the antrum, which is similar to the gastric ulcer. Risk factors for gastric carcinoma include H. pylori or autoimmune gastritis, or even consumption of nitrosamines in smoked foods, especially in the land of the rising sun. Symptoms of gastric carcinoma include abdominal pain, fatigue, weight loss, early satiety, that's enough for me, and anemia. Metastasis, if it occurs, of gastric carcinoma may typically affect the left supraclavicular node, the Virchow node, okay? And keep in mind that the liver is the site of distant metastasis of gastric carcinoma most frequently. Intestinal gastric carcinoma commonly affects the periumbilical area, and this is known as a Sister Mary Joseph nodule. Diffuse gastric carcinoma may involve the ovaries, and this is known as a Krookenberg tumor. And with that, you've completed another very, very, very important lecture. I'm proud of you. Keep up the good work. You're going to make such an exceptional physician in the near future. Maybe a surgeon even. I'm curious to know what you guys are going into. Let me know. Figure out a way to let me know, okay? I'm rooting for you. In the meantime, keep up the good work, and I'll see you later. Take care.